It's five after, so I say we take it away. Asher, I'm going to throw the mic to you. Thank you.
Hello, everyone, and welcome, Maia Szalavitz. It's a pleasure to welcome you here to our courageous conversation. Maia is a New York Times bestselling author, and of course, we all know that Maia is the author of Undoing Drugs, a book that many of us are reading here at Help, and it's timely for us as we are attempting at the moment to implement harm reduction services, particularly in three of our shelters of Ward's Island specifically, but on a broader level, very much interested in incorporating the harm reduction ethos at a broader level organizationally and for our clients. So Maia, what I'd like to do to start off with, since we're reading the book, what I'd like to do is an attempt at a summary of the major themes first that we're looking at, since they do apply to our work here, and then to have a discussion with you about the book, and that discussion, of course, involves several cases. I call them case studies, but several cases, right? In which harm reduction specialists used various strategies and that essentially eventually became the components of the harm reduction framework. Um, and and um, and and the objective of that is to learn from you and to learn how those experiences of the past, and both the past from the late 1980s towards the more recent past, the book goes until about 2020, what we can learn from those experiments and those successes, right? And so to begin, if we take, I would say, the three main areas, of course, of harm reduction, abstinence, and addiction, right? So the first component here really stresses that harm reduction is an evidence-based, bottom-up, multi-stakeholder approach. You present harm reduction as a pragmatic and compassionate public health strategy rooted in empirical evidence, grassroots activism, and very importantly, widespread participation and collaboration among social workers, researchers, parent groups, healthcare workers, community activists, people using substances, and government officials. So originating in multiple international cities during the HIV crisis, including Liverpool, England, and Amsterdam, San Francisco, and New York, you really tell us how harm reduction prioritized saving lives as a human right and a public health concern over enforcing abstinence-based approaches, which at times were rigid and not rooted in evidence-based or scientific frameworks. So programs like syringe exchanges, which we'll talk about a little bit in some of these locations, and the early abilities of physicians in some European contexts to prescribe heroin at managed levels for people that were using, and efforts to expand the coverage of naloxone demonstrated measurable success in reducing disease transmission, improving social outcomes, including lowered crime rates, reduced overdose related deaths, improved health, and as you say, revitalized families. So from its inception, the movement embedded research and community participation, especially from people who use drugs, into its practices, emphasizing dignity, autonomy, compassion, and well-being, and what you call radical empathy. I take all of those things that I just mentioned as part of your definition of radical empathy, prioritizing that over punishment and the tough love approach of previous sort of treatment paradigms. So in this way, um, I think one of the things that we can learn about is the extent to which, these multiple service and advocacy initiatives of harm reduction, and we'll talk about this in our discussion, are experiments in democratic participation and representation. And that sort of comes up against the abstinence-based approach, which is the second kind of area that is covered explicitly and implicitly in the book. So you mentioned quite critically that abstinence-based approaches are rooted in, unfortunately, a history of criminalization and racism and xenophobia in our lawmaking with politicians media linking drugs like cocaine and opium and marijuana to marginalized communities. You describe how laws such as the Harrison Act of 1914 and the Controlled Substances Act much later, the 1970s, were driven more by fear and prejudice than by scientific evidence. The Harrison Act, for example, banned the non-medical use of opiates and cocaine, partly because these substances, as you write, were unfortunately associated with immigrants and minority groups. And these early laws laid the groundwork for the war on drugs in the 1970s, and which informed the Controlled Substances Acts, which categorized drugs into 5 schedules based on perceived danger and medical utility. But as you rightfully note, these classifications, such as placing heroin and marijuana in Schedule 1, the most severe, were not grounded in medical science. And physicians and legal experts often disagree on what constitutes quote unquote legitimate medical purposes, but doctors remain vulnerable to criminal prosecution if law enforcement deems their prescribing practices illegitimate. And so this framework that which you kind of thread throughout the book has also led to unfortunately significant consequences. The federal drug control budget ballooned from 100 million in 1971 to over 15 billion by 2010. The Anti-Drug Abuse Acts of 1986 and 1988 introduced mandatory minimum sentences for crack cocaine offenses, with penalties 100 times harsher than for powder cocaine, disproportionately impacting African American communities. By 1995, you're right, 80% of those incarcerated for federal crack offenses were African American. Drug-related incarceration surged from 19,000 in 1980 to over 237,000 by 1998. And what I think is so critical at this point in your writing is that you indicate that outcomes were not only policy and in these unfortunate areas of incarceration, but they also shape cultural attitudes. They reinforce stigma and criminalizing people who use drugs rather than supporting the health and well-being of those who use drugs. And I just named 3 areas that you mentioned. One was dehumanization. You're right. We value the lives of people who take these drugs less and even celebrate their dehumanization as part of sending an anti-drug message. Stigmatizing illegal drugs and by extension, the people who take them is seen as crucial to prevention. The second one was stereotypes. You're right that by the 1960s, illegal drugs had been firmly linked in the American mind with poor Black and brown criminals. The stereotype of the addict as a lazy, devious, and violent sociopath mapped perfectly onto the racial stereotypes many whites held about those groups. And then also importantly, the internalized shame and stigma, citing the work of the harm reduction pioneer Edith Springer. You quote her as saying that stigma is spoiled identity. And if there's anybody whose identity is spoiled in this country, it's drug users, even their own families, even they themselves, they treat themselves that way. They've internalized it. So both of these paradigms, harm reduction and abstinence, essentially are also combating the definition or the approach or the understanding of addiction. At the heart, and this is the third area before we launch into the meat based on your wonderful work here, but at the heart of that divide between harm reduction and abstinence is a fundamental disagreement about this addiction. Harm reductionists argue that people who use drugs retain agency and deserve respect, even when struggling with substance use, agency and choice. They advocate for meeting people where they're at and supporting healthier choices without judgment. Abstinence-based models you suggest often frame addiction as a disease of powerlessness, portraying users as threats to society who must be controlled, perhaps cured. And what I take the book showing is particularly through therapeutic innovations in harm reduction led, for example, by Edith Springer, is that this framing obscures real progress and reinforces stigma, making it harder for people to seek help or be seen as fully human. You write, real progress is often hidden by the abstinence model. For instance, if someone stops spending all his money every weekend on crack, but still smokes a joint once or twice a month, this doesn't count as a victory in traditional treatment. From the abstinence point of view, that person is still using, is not in recovery and hasn't gotten any better because he isn't abstinent from marijuana, even if he has stopped taking the substances that were most unhealthy for him. But you also note that due to the progress of harm reduction um, in various contexts, but particularly in the United States, the official view on addiction seems, and forgive me if I'm misinterpreting but it seems now to dovetail more closely with the outcomes-based approach of the harm reduction philosophy. As you write, the National Institute on Drug Abuse defines the condition as compulsive behavior that reoccurs despite negative outcomes. So there's an outcome-based understanding versus a different type of understanding that was with abstinence, regardless of whether substances or activities like gambling are involved. I think these areas, these three areas, in the cases that we're about to discuss, there is a struggle on the front lines of dignity, front lines of understanding who substance users are, and then very importantly, the struggle on the appropriate way to deal with services, policy, law, and community with such people, right? And so I think at this point, I would like to really tease your brain in what you've written so wonderfully, starting with those early successes that came outside of the United States, but the activists and the researchers and the social workers had their antennas up, and they picked up on those successes, right? Your book highlights how Liverpool, England's early adoption of harm reduction in the late 1980s, such as prescribing heroin and supporting syringe exchanges, led to measurable improvements in public health, reduced crime, as you say, stronger family outcomes. So can you walk us through the early success in Liverpool in that time, led by John Marks, Alan Perry, Newcomb, and others? What lessons from the UK's evidence-based, even government-supported approach were important to those efforts, of course, but then also the efforts in the United States at a time when harm reduction faced such political resistance?
Yeah, well, I mean, one of the things, there's so many ironies in this, but one of the things that was really important with Liverpool was that, Edinburgh, which was not very far away from, a few hundred miles away, um, had a lot of the same socioeconomic conditions. They had a lot of youth unemployment, they had a lot of heroin use, they had a lot of, sort of just deindustrialization, basically. And yet, when in Edinburgh, there was a doctor who was working with young injection drug users. And this was like the test for HIV had only just been invented.
Right.
And he was just like, oh, I'm going to try out this test because, like, I just want to, see if it works. And this doctor found that like half of these people, most in their like 20s, were already HIV positive. And at that point, it was basically a death sentence. And these, it was, you know, young white people. And I think that sadly mattered because it was just like, oh my God, like your daughter could be sleeping with one of these people, or your daughter might be one of these people. And so the entire UK was really freaked out by the fact that, like, the first time they did any testing, they found half of these people who were tested to be positive. And so Liverpool was like, oh my God, like we're going to have exactly the same problem if we don't act. And so there was really a big crisis. Hold on a sec, I'm going to sneeze.
Sure. Yeah.
Sorry.
Bless you. Bless you. Yeah.
Anyway, so so Liverpool saw that. They had a combination of committed people that were able to do unconventional things. So they knew that Amsterdam and previously Rotterdam had already started providing clean needles to people, and that this was originally devised by a person who injected drugs named Nico Adrians. And It had been successful there. It was not causing problems. So they knew that this existed. They also saw, New York, um, crazy high levels of HIV infection. And when they first checked, they did not have these high rates. So they're like, okay, we got to do something. And so they decided that they would provide clean needles. They had to do this like without judgment. They had to get the maximum number of people who were injecting, whether they were interested in any kind of recovery or not, to avoid this deadly disease. And so they in the UK, unlike us in the 19 teens, they decided that, like, yes, you can prescribe heroin or cocaine to people who are using it as part of legitimate medicine, that this kind of maintenance or, just like safer prescribing, that this could work and it should be allowed. Now, the United States went the opposite direction and we're still suffering from it. But it was legal for them. And this doctor who had just moved to Liverpool inherited patients who had been on prescribed heroin and cocaine for like decades. And they just looked like any of his other patients. Like they weren't especially like deviant or weird or anything, So he was like, okay, we know this can work. Let's expand it. And so Dr. Marks and Alan Parry, who was a former injection drug user at the time, Peter McDermott, another, he was a current injection drug user at the time, and a whole bunch of other people came together. They were lucky in that the head of public health in Liverpool was like friends with Margaret Thatcher. And so, and they were also lucky that the entire country was panicked about, oh my God, this is going to spread from these injection drug users to the rest of the population. And so they were able to just, take action really quickly. The other thing they did that was really smart was before they opened the syringe exchange, they called the local tabloid and they said, we'll give you an exclusive if you just wait till we open. And so that kind of got them on side, because normally the tabloids would have been just like, oh God, giving needles to drug users, it's evil. But because they had this exclusive and because they educated the reporter when they were giving that exclusive, they did not get that horrible media. And they also did work with a local parents group. Again, such groups often are the biggest opposition to harm reduction because they don't understand that it's not about, oh, let's just give everybody drugs or let's just give everybody needles and we're never going to like help them improve their lives. It is about meeting people where they are, because that is the way people change, not by force.
Right. And some of those successes, or many of those successes were sort of introduced to the New York scene, right? With, I believe there was a chance meeting between Perry and Springer.
Yes.
And
Yes.
so now it moves into not just the United States, but where we are right now in New York, right?
Yeah.
You
Yeah.
do
And I
get,
mean,
yeah,
what I think is like really interesting is that, Liverpool never had an HIV epidemic amongst its IV drug users. They actually prevented it.
yes,
We rarely celebrate these successes. Like New York, when we started, when Edith Springer and Alan Perry met, we already had 50% of our injection drug users infected, and that was like 200,000 people or so. And so, and again, this is like there was no cure at the time.
right. And that's like
Um,
88, 87, 88.
yeah,
Yeah,
yeah. By that point,
right,
I mean, like, it turned out that like HIV had been spreading throughout the 70s among injection drug users in New York, and
right,
nobody noticed. Like, doctors actually saw a syndrome in Rikers Island, but they didn't think it was an infectious disease, and they're just like, oh well, junkies get sick. So, um, so HIV could have been discovered a lot earlier if those people had been like, hey, this could be something we should pay attention to. But anyway, so yeah, so Edith, is just she was already at this point, they were providing bleach to clean needles because they knew that politically they were not going to get clean needle access as quickly as they wanted. So they're like, okay, they heard from San Francisco that this bleach can work. And they were just teaching that. And when Edith met Alan, she was like, oh, what I'm doing is harm reduction. Okay, this makes sense. And she trained virtually everybody who became the leadership of harm reduction in the United States in that generation. Um, and, it was like astonishing. So, like, you got Dan Bigg, who was an injection drug user in Chicago who founded the first needle exchange there, and
Right.
who also said naloxone is like safe and like you could, as one of the doctors in his program put it, you could shoot a baby up with it and nothing bad would happen.
Right.
Like it's a really, really safe drug. If you're not, the only side effect it has is causing withdrawal if you are physically dependent on opioids. Like, why can't we just give this to people? And
Right.
so Dan Bigg and the Chicago Recovery Alliance and all the people that he then went on to train, this is why we have over-the-counter naloxone.
Absolutely.
Because
Major
he
contribution
invented it,
at a time of great opposition. And
Yeah, yeah, exactly. And so like in 1996, he started doing that in Chicago. I wrote about it, I think, for the first time for the Village Voice in like 2000.
wow.
Um, and I wrote then and continuously since then, like, we should have this in every first aid kit. It really needs to be widely available. Like, imagine if we had done that then.
Right. Well,
Uh,
what's remarkable to me is, okay, so there are solutions that work and that were acknowledged to work, and there's even an infrastructure here in the United States with organizations like ACT UP and ADAPT who have the um, just the energy and the organizing capacity, and then of course Edith Spring with the training capacity, right? And then all the way into Chicago, Chicago Recovery Alliance. Um, so the thing you do so well is you detail how these organizations, like let's take New York for example, you detail how ADAPT and ACT UP, they push beyond the limitations of of the bleach and teach to actually launch underground needle exchange programs in New York City, which at that time was quite controversial. But
Like, literally the first thing, like Mayor Dinkins, like when he got elected, one of his first promises was, I'm going to shut down the experimental needle exchange that the previous administration had managed to
that's
get
a
in.
perfect. That's what what I would love to ask you about is, so they launched the underground needle exchange program. It's shut down. They face arrest and even trial. It's called the needle aid case. That's one of my favorite chapters in the book, actually. So at that time, so what do you think their actions and the resistance they faced reveal about the power of grassroots activism, the grassroots activism of harm reduction as well? I mean,
Yeah.
particularly
Well, I mean, it was like,
shifting public policy, shifting cultural attitudes, especially when mainstream institutions viewed people who use drugs as just beyond help, right? And like what lessons informed further efforts down the road, because that was so early and they were facing so much opposition.
yeah, yeah. I mean, so it was just very inspiring to see. So I actually wrote about the trial. I actually attended that trial. And it was just like, first of all, for writing the book, piecing together who did what first and who met who and how they figured it out was like a nightmare, because nobody wrote anything down.
Yeah.
Um, but it was, yes, grassroots activism was essential to this, and it was in combination with the public health people as
Right.
well, because if ACT UP did not have the evidence behind it, they would not have won that case. Like, so they deliberately got themselves arrested to prove, because they knew that the data showed that the needle laws did absolutely nothing. They did not like there was this incredible study that showed that like the states with that made needles illegal, because some states just you could buy them over the counter. The states that made them illegal had the highest rates of IV drug use and the highest rates of HIV. They
Right.
didn't have like, so it didn't stop people using, it just spread the disease. And
Absolutely.
so they knew that. And they also had the evidence from Europe. And they had the evidence of their own eyes of just going out and like people being so grateful, like, oh, wow, like, because people didn't know. Like a lot of people didn't know that it was spread because like the news coverage was like really focused on gay men because they were doing activism and people who use drugs were not doing that much of it. And so people didn't know and they were like, oh my God, like as soon as they learned, like me personally, as soon as I learned to use bleach, I just used bleach. Like, nobody wanted to get HIV. And so it was enormously important that they, worked together. And they had some like sort of secret support behind the scenes from the health department. And it was also like what was tragic as well was that the Black community, because of racism, had basically been like, oh, like you're going to give rehab to the white people, but you're just going to give us clean needles and you want us to die. And like you can see why there would be that respectability sort of perspective. And so the Black activists who were, one of them was one of the people who got arrested in one of the Needle 8, Dan Williams. Also a woman who had recently founded the Black Harm Reduction Network, Tracy Gardner. So that they got it from both sides, like, and Keith Kyler, who helped found Housing Works, like they got it, like they were seen as like traitors to Black people for supporting harm reduction, and they were Black people in a very white activist world, so they got the racism from so it was, I mean, they had, and I really want to give them all the respect because it was especially difficult in that intersection at that particular time. But then it very rapidly, thankfully, the mayor of New Haven, Yale, did a study which showed that, gee, when people have clean needles, there's less HIV. And so then between that and the trial, the state was able to say, okay, we'll legalize this. And it was a very long fight. And the it was it was difficult because of that particular intersection in New York.
Sure.
But it was amazing to see. And I should add that you know New York, we had 50% of our injection drug users who were infected. Now it's less than 3%. Now, obviously, some of those people died, but we still have a massive population of people who inject drugs in New York.
Sure.
It's still, I think, the largest in the world.
That's a major contribution. I mean, that's
Yeah,
huge.
and so it went
No,
to,
there's no doubt about it.
yeah, it's
Yeah.
just like, and so there are literally small towns and rural regions in the United States where there are larger numbers of HIV cases among injection drug users. These places have no needle exchange
Mhm.
compared to New York City. And so it's so important to like emphasize that, like, this stops epidemics.
Absolutely.
The whole idea that like people who use drugs are not going to protect themselves is just wrong. It is easier to get somebody to use a
And
clean needle than it is to get a man to use a condom.
right. And I think one of the huge things about that watershed moment is that starts to expand um, all aspects of harm reduction into other spaces that previously weren't there. And the classic example of this is with what happened with Housing Works.
Yes,
Um,
yes,
and so, you know, uh, you describe how Housing Works, which came out of ACT UP, right?
yes,
It
yes. Keith
challenged the
Tyler and
dominant.
yes, the
Go
Keith
ahead, go
Tyler
ahead.
and oh my God, I'm spacing his name, Charles King.
Charles,
Um,
yeah.
like they were in the ACT UP housing, what do they call it, coalition or whatever, and
Right.
they decided to found Housing Works. And I mean, it's still, you can buy their cannabis now. Like they have got a cannabis license.
Right. And I think so that starts in the 90s or so. And you know, this idea that just what you mentioned before about dispelling the myth that people who use drugs don't have control over their choices. You show so beautifully this how a model emerged from one of the earlier residents, and her name is Laura, right? Um, and you show how so they challenge the dominant abstinence-based ethos in homeless services by adopting a harm reduction and housing first approach before anybody else. And so the case of Laura, one of the early residents, helped redefine what progress looks like for people who use drugs and are unhoused. And just to briefly summarize, Laura was that case where she was addicted to crack, and they created a savings account for her, right, where she would have to budget from her public assistance checks. She would have to budget for her essential needs for her family, and then yes, even for her crack usage. And over time, she made the choice herself to stop using crack, and then
Yeah, it was an incredible thing because like so right. So she's like doing this budget. She's actually sticking to it. And then she goes into a store and she sees this coat that would be perfect for her daughter. And she can't afford it unless she cuts out the crack budget of her in her thing. And at this point, also like the crack is just stopping, as happens with crack, like after a while, it doesn't even stop working. It makes things worse, you
right,
know? So she was fed up and she saw this coat. She really wanted it for her daughter. She knew it'd be perfect. And so she like stopped the crack. And then, you know, her daughter loved it and she was she just realized like, why am I wasting my money?
right,
And so, and that is like how her recovery began in like the completely non-traditional way. Like it was like something positive attracted her to stop. She was like, I could get this for my little girl. And it's important for me to do that. And she was able to make that change. And, I mean, as anybody knows, in active addiction, it's really difficult over time to do that. But there are these moments when you see what's going on, and that's when change can happen. And her being housed and her having this support that was non-judgmental and was like, yes, you can have a line item for crack in your budget, was able to, and I think it's really important to stress this because so many times people think that like harm reduction is just like, oh yeah, go use. And
right,
they don't understand that, people who are using are often like overwhelmed by like shame and self-hatred and they get the judgment all the time. It's not like these people are like, oh, you should just tell them to go to treatment when they walk into like a needle exchange. And it's like, do you think they haven't thought about that before?
right.
Why do people avoid treatment? Often because treatment is awful. So, so we got to deconstruct this whole idea of that people avoid treatment because addiction is so fun. People avoid treatment because they've often been abused in treatment, or they've had friends who have been, or they just have heard that it doesn't work, and that it's harsh. So when you offer people like we want you to live exactly as you are. We care about you. We want you to be healthier, but we're not trying to like enforce our like standards on you and like, oh, you have to do this and this and this. It's like, no, we want to have you live your best life.
Right.
And we understand that like if we support you, you will probably realize over time that yeah, crack is not the best way to spend your money. And it is really again, there's all kinds of setbacks and it takes time for people to change, but harm reduction is really about just that radical empathy and that unconditional love.
Right.
And when people feel that they can, you feel safer giving up the only thing that gives you peace and comfort if you begin to see that it is possible to get it elsewhere. And that is what people see at harm reduction sites. And there's so many times when, people, like one of the first needle exchange stories I wrote for the Village Voice, like in the 90s or something. I visited the needle exchange. I interviewed this woman there. I came back a few months later. I did not recognize this woman the next time I saw her because she'd put on like 30, she'd been like a skeleton. She'd put on like 30 pounds. She had asked one of the people who did the needle exchange, "Hey, how did you get sober?" And she was going to meetings. And so, it's like the idea that these things are in opposition is just not a correct one. Like, I mean, even if you look at AA's big book, in chapter 3, there's a part that says, like, if you are not convinced, step into your nearest bar room and try some controlled drinking. Um, and I think there's like this very quaint phrase at the end of that chapter, if I'm not mistaken, where it's like John Barleycorn had become our best advocate because people realize from not being able to control their drinking that they need abstinence. And this is a secret way that harm reduction works for a lot of people. And this is why when people participate in harm reduction programs, they're actually more likely to get abstinent than people who don't participate. So it's so backwards, the ideas that we have about this, and the idea that like, oh, you provide housing for somebody and then like they're just gonna like sit there and be lazy. It's just not about that. I don't, some people do it, but I do not understand how anybody actually manages to get sober while homeless.
Right.
Yeah, brilliant, brilliant. Ashwin, if you don't mind, I want to hit the pause button. We're getting
Okay.
close to time. And so
Right.
I wanted to ask our attendees, put your questions in chat. We'd love to hear from the participants of the conversation. So if there's anything you'd like to ask Maya or Ashwin, please drop it in the chat. And we might go a little bit over if you guys are okay. So let's
Sure.
see if anybody has a question. Let's see. Someone just asked, Tom and Ashwin, did you guys coordinate your outfits? Yes, we did, and we always will.
Of course.
All right, you can count on that. Let's see what else we
It's
got.
Monday after all. It's every Monday.
Every Monday. Let's see if anybody's got some questions. Great comments. Stigma drives politics and policy. Bingo. What is your take on that? Maya, while a few more folks chime in, what's your take? Because stigma is now a political weapon. I mean, it always has been, but it does seem to be
It's
the
just like,
biggest gun in his
yeah,
arsenal right now.
we cannot like we cannot let that divide us. I mean, like one of the things that is just so horrific about this whole thing is that, you know, stigma dehumanizes people. And if you want to like create fascism and concentration camps and all of this kind of thing, you need to stigmatize and dehumanize people. Now, I'm not saying that's necessarily where we're going. I am scared crapless that that is the case, but the thing is that when you actually talk to people with addiction, and I repeatedly have this experience, especially, talking to people, even who are still using or people who are early recovery and people who are homeless, they're people. And once you start to hear their story, it's like, why are we wasting these people? Like they're not wasting themselves. We're wasting them by throwing them away.
Right.
And there's so much talent and love that is out there that we just throw away through stigma. So it's really important. I mean, one of the things that I have tried to do is like, okay, I'm a white woman. I don't look like the racist stereotype of a person with addiction. so I can be out about it and I can work to destigmatize that because people don't suspect me. And so if you have that privilege, it is really, I think it is really as important to like try to be out and to use that to say that this stuff is nonsense and to support the people who because of stigma cannot speak out and just fight it all the time. One of the critical things, and this annoys the heck out of me, the whole point of criminalizing something is to stigmatize it. Like that
Right.
is what criminalization is for. It is not to punish people, it is to deter people by stigmatizing the people who do that action, right? Obviously, if this were effective, we wouldn't be sitting here. But also, the you know, this is like this is what it's for. Why are we doing something that is so ineffective and so dehumanizing? And so, I mean, you get people like say, oh, look, Oregon, it didn't work. No, that's not what happened in Oregon. What happened in Oregon was that fentanyl arrived at the same time as decriminalization. And if you look at Idaho, which is right next door, and fentanyl arrived there at the same time, they had the same increase in overdoses. Like, yes, Idaho does not have a lot of homelessness publicly visible drug use. Same thing in Washington. They decriminalized a little bit by mistake a little bit earlier because a judge ruled that their criminal laws were wrong. And when they recriminalized, overdose went up because that's when the fentanyl arrived in Washington. And so, this whole idea that like, also if you think about it for 5 seconds, like they did interviews with the homeless people there. They're like, how many of you like knew that fentanyl was decriminalized? And it was something like 10%,
Mhm.
because they couldn't believe that that would actually be a thing given, and also a lot of people who are unhoused are not following the news about state and local law changes. Um, and so the whole idea also that there were some people that were just sitting around being like, I'm not scared of dying. I'm scared of getting arrested. And now that possession is decriminalized, I'm going to go try fentanyl. Like, how many such people exist? Like zero.
Brilliant. Thank you for that. I have another question from Avery. I won't keep you guys much longer. Homelessness is another layer of stigmatization. Do you have any recommendations on how we can support our clients?
I mean, the best thing to do is just be there with them, and uphold their dignity and treat them like you would any other person. And like talk about your day or just like, try to because every place, when you're unhoused, like people are kind of walking across the street to avoid you because they don't want you to beg. And like it's just the stigma is so real that to be in a place where people value you just as you are is enormously healing for a lot of people. Now, this doesn't mean everybody's going to get into recovery instantly, but the way to do it is to like live it as a person to, just be kind. And I know that sounds like obvious, but that really in this environment is one of the few things each individual can actually do.
Brilliant. Thank you so much. We've got another question. Fallon, I think I saw something from you. No, I don't see it.
I saw it too.
Yeah, it disappeared. That's so weird.
Okay.
I don't
Uh,
remember
may,
what it was. I just saw something flash up and then it's gone.
maybe you answered it. I guess I'm going to go with that. And we are at time. I don't want to keep our panelists any longer. Thank you so much for your time. I would give you both back the microphone and say, are there any closing comments? Was there anything you wanted to make sure that we heard today?
No, I think like just, understanding that harm reduction is evidence-based and all these people who are just like, oh no, like we have to be tough on crime, like politically, don't know what they're talking about. Um, like if you actually want to solve the problem, as opposed to elect somebody by creating fear, if you actually want to solve these problems, harm reduction works, and it is not in opposition to abstinence.
Mm. Brilliant, brilliant. You're getting a lot of thank yous and a lot of appreciation in the comments, and I can only second all of that. And
Likewise.
Ashwin, thank you for bringing this book to our attention, and then of course Maya into our community.
It was a pleasure speaking to you, Maya. Thank you so much for your knowledge and your book. And I hope we continue the conversation.
Yes, likewise. And thanks to you all. And now I'm going to get lunch.
There you go. I think we're all in the same boat. Thank you.
Have a good one. Take care.
Thank you
Thank
guys
you.
so much. Thank you everybody for
Thank you
attending.
so
We
much.
really appreciate all of you. Thank you guys.
Thank you.
Bye-bye.
Bye.